it's so far on debating skills, and I do agree that on technical solidity, Dr. Samresh's presentation was definitely more sturdy.
So, size does matter or does it not matter?
Your case does matter.
Yes, we have the two batsmen, Dr. Suhas. Dr. Suhas is here, and Dr. Panneerselvam, please. Come. Who's going to bat first? You? Dr. Suhas is going to.
Good afternoon. Thank you, Dr. Ahmadi, for this invitation. After a very colorful, when we advise a particular procedure, we should always be looking at what is that's going to happen 10 years down the line, 15 years down the line, and we should not be looking at the short-term gains. Well, the modern science has shown us many ways to go forward in surgical management of various conditions. Some failed, some had some inbuilt flaws. Cataract extraction is one of the most highly developed and successful surgical techniques which all of us agree. And we continue to reap benefits from it for patients and for self. But we should remember that clear lens extraction in high myopia is a different ballgame altogether. There are events that occur before, during and after the clear lens extraction that are harmful and sight-threatening to the patient in spite of all the advances in present-day technique. All of us do cataract surgery. And when it comes to doing even a cataract surgery in a myope, there are a lot of things that go against us. We have to be very careful with regards to whether there is excessive turbulence in the eye, whether the chamber instability is high or low, are we using two higher parameters for fluidics? Because every time your phaco tip goes in or your irrigation tip goes in and the AC deepens, there's such a huge pressure variation which is definitely deleterious and damaging to the peripheral retina and to the posterior fold. And we know that we are dealing with a diseased eye, and these things really matter. At such times, are we doing right when we advise a clear lens extraction? High myopia has several options. We can still continue with glasses. We have contact lenses. We have such a lovely procedure like ICL. Or we could even do LASIK and overcorrection glasses or contact lenses if the patient really is so much bothered about not using glasses. And we should always remember one thing: the optional surgical procedure needs a higher degree of safety than a procedure performed for medical necessities. The current evidence has shown that possible optical benefits of clear lens extraction in axial myopia are usually outweighed by the severity of this risk and the complications and by the availability of safer alternatives. We have several studies on the complications of clear lens extraction for high myopia. This is one of the many studies which says that 61% of the patients they operated for clear lens extraction required capsulotomy at the end of 7 years, 20% required argon laser retinal treatment, 16% had posterior vitreous detachment, and almost as high as 8% had retinal detachment at 7 years, in spite of very proper post-op regimen for looking for retinal problems and doing retinal lasers. So this is definitely very hard. The incidence of retinal detachment after clear lens extraction was nearly double than that for persons with myopia greater than -10 who do not undergo clear lens extraction. With clear lens extraction, you have to lose your unaided near vision, which can be happily retained when ICL is performed. Only half a minute. When you have a relatively safe procedure which is reversible and lot less traumatic, why go for such an invasive procedure which is difficult to master to a level where it can be advised for high myopia? When I say it is difficult to master, It's different when you do a cataract surgery for a normal eye, but when it comes to doing clear lens for a high myope, you definitely need to be doing it with extreme care. In conclusion, I strongly propose that ICL should be the way forward for high myopia till such time that we find a better technique. Thank you.
Dr. Paneerselvam.
Good evening. I'm a great admirer of Dr. Suga's surgical skills. But his talk on clear lens extraction is a surprise to me. Anyhow, my concerns of ICL are based on anatomical, surgical, economical, and risk versus benefit. Anatomical. The posterior chamber is not like anterior chamber. The volume is only 65 microliters. On a cut section, it is a triangular structure with the base pointing towards the ciliary process. So the apex is at the pupillary point, wherein the maximum size of the ICL is placed. And the structures coming in contact with the ICL, the ciliary process, it rests on that, only by that it vaults forward. So it is always in touch, and you are going to place that lens on a 20-year-old boy or a girl. In the remaining period of their life, it is going to press on that. And what about the posterior surface of the iris? The will release. And the effect of age. Only the posterior chamber is not a stationary one. As you age, the lens becomes thicker, and the anterior chamber gets reduced by 7% every decade. So both sides are going to be compressed, and the posterior chamber is going to be narrowed like a sling. So this is where we are going to place implantable contact lenses. The next is surgery. Any skill for that matter. Only when you practice over a period regularly with passion, you can master. And in ICL, the lens design is changing, and you have a very low volume. You don't operate every day. And the cost is phenomenal, and the patient's expectation. You can see those patients. The parents there, they expect you to do something good, and you are not sure about your own skill, and you are not sure about the long-term data, and do you really want to do that? Finally, economical. The cost is phenomenal. Not everybody can afford that. And those who afford, they have a high expectation, and they will take you to task if you don't perform well. Remember that. Finally, the risk versus benefit. This is the latest article I got. Even though we have a lot of articles, I took this because of the 15-year follow-up. See that 15% of the people had IOP elevation, 38% had cataract, 3% uveitis, 36% ovalization of the pupil, and 30% IOL explantation. You really want to do that? So when I looked at it, then I wanted to have a reliable source, what I can tell the patient or what I can gain. And I got a very reputable source, and the first word they say about risk on ICL is, you may lose vision. I don't think any other condition in eye that we say, first thing, you may lose vision. Yes, in cataract surgery, people can lose vision, but we don't tell it the first. But here, that source gives us a lose vision. What are the other things? Debilitating visual symptoms, resurgery, undertreated or overtreated, cornea can become cloudy, development of cataract and detachment, and long-term data is not available. And who gave this source? FDA. Remember, it is at fda.gov, you can go and check. So the same thing, why I prefer clear lens section, the same thing, anatomical. What other place can you place a lens except in the back? It's a natural process. And surgical, day in and day out, we do that, and it's not difficult to master in a myopia. And economical, you know that. Finally, the risk versus benefit. What are the things that we can lose in a young patient when we operate a clear lens section? Loss of accommodation, retinal detachment, and posterior opacification. But improved surgical technique, accurate biometry, excellent IOL is coming in, and the surgeons sitting, retinal surgeons, they can do anything, and they have excellent results. What else you want? So friends, what is needed is not all things new are good. What we require is a change in mindset. I graduated in 1986. At that time, we were doing intracapsular. When we go out to the screening camp, we were asked to select patients 1/60 or mature cataract because the safety was not there. But now you know the results. So the same thing now, press the of the gauge, people are opting for multifocal IOLs, accommodative IOLs. The same thing, why not we do it for a clear lens section? Not for all myopes, I am suggesting clear lens extraction. Only for people who really need it, deserve it, after selection, this is the safest rather than IOL. ICL, sorry. Thank you.
Dr. Suhas, when you spoke, I thought ICL was fantastic. When he speaks, I think, oh, what is this? I seem to like what Panir says. Yes, defend yourself, please.
Well, when you compare techniques, you don't really take cost into consideration. Now, cost, here we are talking scientifically about two techniques compared. And the results that he speaks of for 15 years study. See, that was a time...
The complication rate was almost 130% in 15 years, more than 100% usually.
So that was a time when this technique was evolving. If you take last 5 to 7 years, and especially if you take last 2-3 years, when the lens has evolved, it's definitely much. See, he's talking about the ovalization of pupil and IOL explantation. Now, most of us who are practicing ICL here, I'm sure they'll say these are very absurd figures, because that's not the kind of complication that we get today. Because, see, with evolving technology, all these days we were really worried about actual sizing. And today with different machines, we can have a perfect sizing. In fact, now when you operate for a clear lens extraction, imagine the amount of, the trauma you cause to the retina in general is something that you really can't. And here, as compared to clear lens, ICL is absolutely least traumatic. And all these complications will not occur today with the newer way of diagnosis and the newer design of the lens. That's what I think.
Judges, any question?
No, I think both points were very well debated, and we both agree
Questions?
that I think...
Any questions?
No.
One question was, you were so worried about the cataract surgery that he is doing, that the myopia is different, it reacts different. Now, according to him, the cataracts, because of the ICL, is over 38%. And because of old age, probably 10, 20 years down the line, they also develop a cataract. And at that time, when you are operating on a cataract, the same eye is myopic and he's got all the problems. He's going to get all the problems that you're so worried about now. So when you're going to plus an added problem of removal of the ICL. So don't you think that you will be probably doing injustice to him later on in life? Because you are going to do the same, sir. You're going to have the same detachments, you're going to have the same peripheral problems, you're going to have the same drop nucleus and the various other things that has been coming up.
See, here you're comparing two things. At that time, well, removal of an ICL is not an issue at all. But a cataract developed myope, it's not an optional procedure. There, it's a necessity. Today, it's optional. And that's the reason, might as well go for a safer procedure. When he develops a high myope, develops a cataract, do you have any other option? No. That's the only option. I mean, that's the only choice. There's no option.
As far as retinal detachment is concerned, there is a study there. Retinal detachment after ACL was 4.8%, and retinal detachment after CLE is 2.1%.
Next group, I think, can I call Dr. Nipian? Ramana Kumar has come?
Yes, sir.
Yes, yeah. The Ramana Kumar and Dr. Nipian. When a patient lands up with diabetic macular edema, it's a very interesting and evolving topic and controversial topic. Ramakumar says that he would like to routinely do OCT and give them a shot of intravitreal avastin and go ahead, whereas Nivian feels that an FFA is mandatory and then he will prefer a laser in these patients. Dr. Ramakumar, you are buddy first?
Yes, sir.
Against Dr. Nivian on the FFA machine. Okay, how many of you have actually gone through the FFA consent form before addressing FFA for anybody? If you go through, I'm sure nobody will have an FFA done. Have any of us actually told the patient that you will have itchy feeling all over the body? You will feel breathless, you will feel nauseous, we'll shift you if necessary. Have anybody told this? We have to tell the patient that the patient can sometimes collapse. It's going to help your kidneys function better with the dye going in the body. And there is a 1 in 2 lakh chance of death. Have any of you told your patients that? Honestly, there is always a first time for everything. Okay? So FFA is definitely not a very safe procedure to start with. The other simple facts, it takes always more than 20 to 25 minutes to do an FFA, whereas an OCT hardly going to take 15 to 20 seconds. You don't need an IV needle, you don't need a vent flon, you can put up with a vent comprehensive patient, you don't need a physician anesthetist standby, and more importantly, if you show the OCT printout, the patient is able to understand the pathology much better. What does FFA do? It helps us to understand the so-called pathophysiology of diabetic retinal and RBO and AMD much better. But what the OCT does, it's, let's get practical. It tells you when to treat, what to treat for, and probably is the best imaging modality. Accepted, the FFA does show some things that the OCT cannot show, like it can sometimes pick up an occult NDE for you, it can diagnose macular ischemia, and can diagnose peripheral CMP areas. But honestly, for everything else, the OCT is better. Okay, OCT today has made actually the general ophthalmologist a medical. It's the very definition of diabetic macular. Nobody talks about CSME. CSME is probably for your exams and it's out of the window more or less. We talk more of the studies are today are about whether the edema involves the center or not. It is about center involving or non-center involving. Okay? And the other thing OCT has done is given a total new classification about diabetic macular edema. You have 5 different types. There used to be time when the macular never goes off. We used to keep hammering the retina with more and more laser, hoping the edema will come down. But today we have these 5 types of macular edema with which you have a fair idea. The first one is spongiform. The second is serous macular detachment, which I'm sure no OCT machine can show you what is a subretinal fluid. It shows you what amount of cystoid macular edema is there. It helps you to quantify even though the FFA shows up. Most importantly, it tells you when you need to go in and operate on a patient with diabetic macular edema. It shows you what is called as vitreomacular traction syndrome and tells you what is called as a taut posterior hyaloid. Another 2 pictures of taut posterior hyaloid. This patient you see, anybody would say this patient would need laser, but in during OCT you see that there is a definite traction there and this patient actually needs surgery. Now, not only does, accept that the FFA does show what is a cystoid macular edema, it's good for academics, you can show the petroloid leakage to your PGs and colleagues. But what is the use? You need an OCT to find out how much of edema is there, you need to know whether there's subretinal fluid, and more importantly, you need an OCT follow-up when you treat the patient like 2 weeks, 4 weeks, or 8 weeks when you're doing anti-VEGF. There are enough studies to show that today, between the correlation of FFA and OCT in the diagnosed CME, the SD-OCT is as good as a FFA. And we have all the trials, be it whichever, the RBO trials, the AMD trials, or the DRCR, do OCT as the imaging modality for follow-up. In AMD, we know nobody can ever dream about treating a wet AMD without an OCT. It is as good as in dry AMD as well. It compares very good with fundus fluorescence and autofluorescence. And there's something called enhanced depth imaging that has come up of late, wherein the choroid gets completely exposed. Anything beyond the RP, the FFA actually cannot see. So what is the use? Whereas the OCT nowadays can actually see up to this clear. The FFA only is going to show the vascular filling pattern of retina, but OCT can show you the structural layers of the retina, the choroid, the RPE, and grooves. In today's context, honestly, if you're a retina specialist, who's just started specialty practice, what would one buy first? I know most of you think it's an FFA, but actually, if you see in a retina clinic, how many FFAs versus OCTs are done in a month or a year or a day? I'm sure most of retina surgeons will do more OCTs in a day than an FFA, which just shows that instead of paying a consultant and actually buying an OCT machine, it's the best consultant you can ever invest in. It makes you more money. Coming to the practical aspect of breaking even as well, the average cost of OCT is 2,500 for both eyes today, whereas FFA is around probably 1,500K. And I'm sure the number of OCTs done for diagnosis or follow-up are far more than FFA because thanks to the conditions we have, we literally have to do OCTs every month for at least 6 months. Now coming to the printout as such, you don't actually need to see the fundus at all. If you see the diabetic macular edema printout, it actually shows you what is the thickness, it shows you the hot area, shows you where the thickness is, how much of thickness is there, the lower OCT picture shows you how much of CME is there. Okay, coming to the final couple of slides. Okay, FFA is a good machine. It's nice to, sorry, just one moment, last 2 slides. It's nice to have in a clinic, use it once in a while, but with drilling indications. But FFA is something that technology has come in the last 10 years. It's made retinal practice easy for general ophthalmologists, and it's what the future is all about. I don't deny the fact that FFA is a damn good investigation for retina specialists, but we need to understand that in today's context, the OCT is a far better machine. Thank you.
Dr. Julian?
Yeah, respected teacher, answer post-operative endophthalmitis, redetachment, silicone oil, positioning, and for all cataract surgeons also, we go through our consent form, you can see. So these are 3 things I should tell before I start my presentation. And first, let me go through the history, the machine, the clinical features, FFA over OCT, and diagnosis and classification, and deciding on the treatment. History. Why am I talking about history? The first angiogram was done in 1961, and it has been 50 years since the angiogram, and most of us here, I'm sure, have an FFA machine still in our practice and are doing FFA. So this shows there is a definitive indicative role for fundus fluorescent angiograph in treatment of diabetic macular edema. And I also have a small box here which shows my score to make it easier for the judges. As far as the cost, there is no debate in this, and for the maintenance, I know because the fundus fluorescence is based on photographs and filters, it's easier to maintain. And advancements, yes, OCT might talk about all the spectral imaging, high definition imaging, choroidal imaging. Yes, even fundus fluorescence also has got its advancements, and you can see the images in which you can even see the venules and even each and every, and see how good you can see the foveal avascular zone. And this one picture is enough to tell everybody here that what diabetic retinopathy and diabetic macular edema is all about. It is not only about the center. Yes, the center had edema, you are treated with laser, but you are wondering why nothing is improving. It is because of the CNP areas in the periphery, you have NTEs, and these are the contributing factors for the central diabetic edema. So you keep only looking at the center. What about the remaining part of the retina? Who is going to see that, and what are you going to diagnose, and how are you going to treat the patient? So I'm not going to go into this. And there are just a couple of studies which compared OCT and FFA for macular edema. They also found in this study that 4% of the patients actually OCT did not pick up the macular edema or any morphological changes. As far as OCT classification, Ramana Kumar has very clearly explained it is focal edema, spongy edema, cystoid cavities, and serous detachment. But now let us come to the treatment aspect. So what treatment is Ramana Kumar going to do here? Yes, he's going to give IVTA, he's going to give intravitreals, and intravitreals. So where is the role of laser in this? Yes, you might have steroids, you might have anti-VEGF, Lucentis, Ozurdex. But then, when you classify it according to fundus fluorescent angiography, you have the focal leaks, you have the diffuse leaks, and then when you come up talk about the treatment options, you have the focal laser, you have the grid laser, you can also combine the focal laser with the intravitreal injections. So these are your various treatment options when you treat the patient based on fundus fluorescent angiography. And pathogenesis, yes, it is a microangiopathy and it's something connected to the vascular system. So no better treatment than the fundus fluorescent angiogram to show you all the phases and what is the disease all about. If you see this clinical scenario, I know most of us would rate this as moderate, or some would say severe. I know, and some of the retina specialists would say like a featureless retina. Yes, and the OCT might show some macular edema. And what is he going to do? Again, going to inject again. But then only when you do FFA, then he's also supported that you find this case of macular ischemia, you see the dropouts, and vision is not going to improve in this. So how many times are you going to inject this patient just looking at the macular edema? And after how many months are you going to decide, let us do an FFA to find actually what is the cause for the loss of vision? And according to what he said, all the studies of BRVO, this thing also said that definitely laser has a better role and long-term effects than intravitreal injections. And always remember, intravitreal injections, the rate of endophthalmitis is low, yes, agreed, but it is not zero. And this is this CTDRS study by the DRCR net in which everything has said that laser has better effects. And this was a meet that happened last week in Mumbai, in which I think Ramana Kumar was also present, and please listen to this carefully. Remember the volume? Volume.
God is there, everyone. Have faith. You know? God is there. See, volume.
This is a meet on DME in which Susan Bessler was talking. You can see the famous person sitting on the dais, and Ramana Kumar was sitting next to me. And all she said was how important the role of initial angiogram is in classifying and treatment of diabetic macular edema.
To help me answer, okay, now why is the edema persisting, or why has the edema gone away, and yes, the vision did not improve. So I do prefer to have an initial angiogram before I initiate therapy. And then for the most part, I don't keep.
So I would conclude by saying, yes, FFA alone is like the certificate of our team, which is greatness, glorified, time-tested and godlike. Yes, some new people have come in and that's the OCT, it's more flamboyant, more fresh and more fantastic. But I would, as a retina specialist, like to conclude by saying, in a retina practice, only when you have both the FFA and the OCT, do you do 100% justice to the patient as far as treatment is concerned. Thank you.
Dr. Ramakumar, you have 1 minute.
Yeah, okay.
Counterpoints to...
I'm just going to counter what Dr. Vivian said. I feel very sorry, we have to compare a technology that's invented in 1950 whereas a technology invented in 2001. Coming to the first point, he keeps repeatedly referring back to ETDRS, which was started in 1988. And honestly, most of you will accept that the role of laser is the number of normal angiograms. Then we feel, okay, there will be one small area of peripheral capillary non-perfusion. So then we think about having a wide field optos. And the other thing is, optos, how expensive it is costing twice or even thrice the cost of an angiogram.
The normal fundus fluorescent angiogram, you can do all the graph.
Fine, okay. The other thing is, about the macular ischemia. Yes, macular ischemia is one area. I'm not saying FFA is not totally out of the window. Macular ischemia does help you to find out, but at the end of the day, you're not going to do anything for macular ischemia. The other thing is, honestly, after speaking so much for the angiogram, Dr. Naveen has purchased a new OCT machine himself about a few months back. Okay, which just shows how much faith he's got in FFA. And lastly,
I have two fundus fluorescent machines.
Yeah, then why did you buy one? You don't need one, isn't it? You can send the OCTs to me. The last thing is, honestly, I think most of you will accept, I prefer to have Dhoni alone in I don't meet any Tendulkar anymore. Okay? Dhoni is enough. He's good enough.
Judges?
He gives results. And all of you know that.
Yeah. Both OCT and FFA are complementary to each other. We've both spoken very well, but in terms of debating skills and and counterpoints, I think Dr. Nivian wins.
Thank you.
Thank you, sir.
Can we have the next two speakers? Dr. Murali Ariga and Dr. Krishnadass. Says Murali, I will not treat, says Dr. Krishnadass. Dr. Murali.
Thank you, sir. Basically, the issue here is, do I treat pre-perimetric glaucoma or not? So I think that before even start saying something, I think a checklist should be, we should ensure that we treat pre-perimetric glaucoma. Why should I say that I want to treat pre-perimetric glaucoma? Obviously, I won't say it unless I have some solid evidence for that. The evidence to that is that we have various studies, numerous publications showing us that changes in glaucoma first occur in the disc and the nerve fiber layer earlier, and subsequently we start seeing changes in the visual fields. And we have numerous studies again showing us that the extent of ganglion cell loss, at least about 30, 40 and 50%. We have many patients like this. We have this apparently normal looking disc, little asymmetry, nerve fiber layer defects, open angles, and we have normal fields, and typically we have nerve fiber layer defects. This is of course reliable fields, reliable OCT, and typical changes in nerve fiber layer looking like glaucoma. And we also have various other technologies like the RTV, which will show you pre-perimetric examples where the technology shows you changes in nerve fiber layer and the thinner ganglion cell complex as compared to fields which are apparently normal. So I don't think there's an issue about how early we can pick up glaucoma. We do pick up glaucoma earlier using imaging technology, using GCC analysis, using RNF analysis. The fields are definitely going to show up changes later. So, but what actually puzzles me here is this one. Here we have Dr. Krishnadass standing across the dais here, talking about I don't treat perimetric glaucoma. In the same hall, 2 days later, he's going to talk about importance of RNFL changes in glaucoma. So that's Dr. Krishnadass for you. You see the change in color in the chameleon there? And then of course, what is more puzzling to me is number 2, is the refusal to accept new technology. So we all know that perimetry is old hat. We have changes in the visual field, we all have evidence that things are happening much, much later in the disease. Whereas here we have technology which is proven evidence that you are having changes in the nerve fiber layer much before changes in the visual field. I think all of us must have come from Delhi to Agra, and I'm sure we will use technology something like this. Maybe we have to come in. Any of our modern doctors, I don't think we would be using any old technology. Some of our learned doctors coming from Delhi to Agra using perimetry for diagnosing glaucoma would be something like this. We really can't accept. How would you say that you will treat glaucoma only when you see a visual field defect and when you see it in the optic nerve?
Is it you, Krishnadass?
I don't think it was familiar, but I'm not going to point fingers. So early diagnosis actually, ladies and gentlemen, is the way to go. Be it cancer or be it any other disease. Here you have early diagnosis, alert diagnosis for various cancers. And we are sure that we want to diagnose cancer early. And same thing goes with glaucoma as well. We want to pick up changes much earlier. We don't want to pick up 50% RGC loss and then say you're doing post-mortem analysis for the glaucoma patient and say, yes, you have glaucoma. So here's of course tuberculosis for you, the pipeline of diagnosis for tuberculosis. You look at the years below, 2007, 2008, 2012, 2013, you will find so many tests now available for glaucoma, for tuberculosis, that is not even in the pipeline. Some of them are way ahead of what we have today. So obviously we can't outright reject and say I will go only for sputum analysis for tuberculosis. We are far ahead in technology. I think we really should accept technology and the evidence that is staring at us in the face, and you can't say I am not going to treat pre-perimental glaucoma. So let us not miss the bus while we ponder. Ladies and gentlemen, early detection is the best defense against glaucoma. If you are going to wait, and if you are going to wait till you miss the bus, I think you're going to cut a sorry figure, something like this. I hope the video plays. There's a video there. I'm trying to see if you can play that. Not running. It's a very interesting video of how to miss the bus. The opportunity stares at you in the face.
Let them hear me talk and then let
Dr.
us see whether
yes.
They missed the bus.
Also, we are a bit short of time.
Okay.
So,
Thank you, Murli. That was a brilliant talk. Do I ever stand a chance? Perhaps no. But I normally don't oppose Murli for two reasons.
Here you are with the bus, Dr. Krishnadas. Just give me about 30 seconds.
really short of time.
I think I'll
we have two more sessions,
Sorry.
two more debates here.
I'll stop. I think my point is pretty clear. I don't think I need to show any bus.
I don't oppose Murli for two reasons. One, he is very, very scientific, brilliant. Number two, he is my wife's classmate, so I never attempt to stamp him on the wrong side. But today he has chosen to speak against any evidence that is much available, probably for the reason that Mati wanted him to speak, his boss. Now he reminds me of modern day Karna. Now he wants to speak against Dharma because of his reverence to his boss. Now let us see why I will not treat with the presence of RNFL thinning and normal fields and optic discs. Oh, sorry. Okay. Now, for pathologic diagnosis of disease, we need to have a very clear-cut examination, come to a pre-test probability estimation, and then do the diagnostic test to come to what is known as the post-test confirmation of disease. Now, even if the likelihood of abnormality is very high, if the pre-test odds based on clinical examination is very low, like in the particular case, you have an ocular hypertension with hardly any evidence of disease, so that pre-test odds of a disease approaches zero, the post-test odds of the disease from the simple equation, friends, you know well, is close to zero. Now you have a field like this. Would you treat him for glaucoma? It's tubular fields. Now his pressure is 30 millimeter of mercury. Probably you would. Corneal thickness 600 microns. Yes, probably it is still glaucoma. But look at the optic nerves. Now what does this say? We have what is known as Bayesian inferences, where the probability of clinical diagnosis influenced not only by prior probability, but addition of new information, and probability of diagnosis being correct increases as additional information consistent with that diagnosis is acquired. Now where do you have all these evidences in the set case? Now the structural assessment based on RNFL assessment and glaucoma has several shortcomings because of the large variability in the structural characteristics, overlap in the structural measurement characteristics between normals and early glaucoma, and anomalous structural features that conform the current existing software and algorithms, leading to misclassification and misdiagnosis. Now, currently the disc margin is depicted in the imaging technologies as a true border of neuroretinal rim, which is inaccurate and leads to fallacious RNFL measurements. There is definitely a discrepancy in clinically detectable disc margins, which is shown in the green here, and it does not correspond to the actual termination of the Bruch's membrane, which corresponds to the limit, the outer limit of the neuroretinal rim. Now, how effective is ocular hypotensive therapy in reducing conversion of preperimetric glaucoma to overt glaucoma? If you look back at the evidence from ocular hypertension study, we need to go to what is known as the absolute risk reduction and number needed to treat. Now, as prophylactic treatment, which is the case we are dealing with, the number needed to treat should be very, very low. In this case, in ocular hypertensives, the absolute risk reduction is 5%, leading to number needed to treat is 20, by which means you have to expose 20 individuals to the risks of treatment, medical or otherwise, to prevent one person from developing glaucoma from ocular hypertension. Now, moreover, what there is also known as number needed to harm. All treatments, including medical, have adverse events, and Sigets showed that for every 11 persons treated medically, one would require cataract extraction. Now, what are the considerations in deciding justification to treat? It would definitely depend on rate of change of disease in the absence of treatment. In this case, this is cross-sectional. We don't have any evidence on rate of change of treatment. Now, to summarize the role of imaging in glaucoma practice, the information obtained from imaging devices is useful in clinical practice when only analyzed in conjunction with other relevant parameters that define glaucoma diagnosis and progression. So the case in point is at risk of glaucoma and requires close observation rather than ocular hypertensive therapy. Thank you.
Dr. Murali, you have 30 seconds.
I think the point, whatever he said actually reiterates what I actually said. The sense that imaging technology picks up disease early and that we are picking up glaucoma earlier. What he's trying to say is that in ocular, most of the point which he's making is actually about ocular hypertension, which you don't actually see RNFL changes. So I think ocular hypertension we don't need to treat unless we are really evaluating the risk of developing glaucoma in the next 5 years and so on. But we are seeing clear-cut changes in the RNFL that look like glaucoma. If it had been a parent, if it had been a relative, I think I would treat.
No, my point was that I have a chance. I have another chance.
I think judges will be. Yeah, judges.
The winner is Dr. Krishna Das.
For science.
So you say they could give a treat.
For debating skills, and we think over-treatment shouldn't be the case.
Thank you.
Very well brought up. Both speakers brought up points very well. Thank you.
We have Dr. Sri Ganesh and Dr. Umesh.
And also because it's the most non-polluting way to come to the
Dr. Sri Ganesh will be answering the thing. When the patient has a pre-existing astigmatism and a cataract, what will he like to do? He says that he would like to implant a toric IOL, whereas Umesh is saying that he will implant a routine aspheric IOL and have add-on procedures to control the astigmatism. Dr. Sri Ganesh.
Good evening, dear friends, and thank you, Dr. Madhivanan, for inviting me to this debate. So I'll be speaking for toric IOL, my choice for correcting astigmatism along with cataract surgery. Have you heard the term res ipsa laquata? The thing speaks for itself. Let us look at our patients after LRI, when they're still left with glasses because it's not an effective procedure, and they keep rubbing their eyes because of the irritation that it produces. And after toric IOL, you have the young lady smiling beautifully and very happy. So how do you want your patients after surgery? You'll have to decide. What is the best to correct astigmatism when there is cataract? Relaxing incision, toric intraocular lenses, or cataract surgery followed by LASIK, placing surgical incision. There are different options, but my option is a toric intraocular lens. If you look at the additional corneal refractive procedures like LRI, incision at steep axis, or doing a LASIK PRK, outcomes depends on multiple factors: age, depth, length of incision, attendant risk of second surgical procedure, etc., etc. So it has its drawbacks. With a toric intraocular lens, you have efficient correction of higher degrees of astigmatism with precision using a single step small incision approach without any corneal tissue manipulation. It doesn't require any new skills for the surgeon or an additional procedure. Let us look at what surgeons prefer. This was a new iWorld article, latest iWorld article, which clearly says the bottom line for me is that toric IOLs are a safer and more effective methodology for managing corneal astigmatism at the time of cataract surgery. Most of our esteemed colleagues believe in this. Let us look at what are the advantages, disadvantages. Mode of action, toric IOLs, it corrects at the IOL plane. There's no corneal tissue handling, whereas LRIs, the flattening effect depends upon localization and length of incision. Large incisions required to have a substantial effect. Most of them don't work for astigmatism over 1.5 diopters. Predictability and efficacy. Toric IOLs, more precise, predictable, reliable, stable, no risk of regression. Here it's surgeon dependent, variable, unpredictable. You can get overcorrection, undercorrection, changes due to wound healing, regression. Range of astigmatism, yes, you can correct up till 11 diopters with a toric IOL, but with the corneal incisions, you can correct only 1.5 diopters. If you go closer to the visual axis, it's very irregular, very unpredictable. And calculation for a toric IOL is very simple to calculate. You have online calculators, the company calculates it. For LRIs, it is very complex and you have multiple nomograms because no nomogram works. Reversibility, yes, if there is any problem in the toric IOL, you can always reposition it in the post-op period. Whereas if you make a corneal incision wrong, you get your axis wrong, it is irreversible. Patient comfort, toric IOL patient is very comfortable, no discomfort post-operative. But with corneal incisions, you have post-op irritation, you have high risk of infection, wound healing problems. And even if there is peripheral thinning in the cornea with the toric IOL, you can still correct the astigmatism. You have PMD or if you have keratoconus, but with the corneal incisions, it's unsuitable. Side effects with toric IOLs, hardly anything. Whereas corneal incisions, you need incisions more than 120 degrees. They denervate the cornea, causing dry eye, and especially in this cataract age group, most of them already have dry eye. You're going to add to the dry eye. There's an increased chance of infection, delayed healing, wound gape, and even perforation because you're not precise in setting your incisions. Let's look at this, just a small video of LRI, and then can you play that video, please? Can you play the video? It's loading now. Sorry about the delay. But here you can see that this is a LRI being done with a diamond blade. Okay, and there is no way to know what is the thickness in the peripheral cornea. You think everything is fine. Can I have the sound? Okay, you think you have created a perfect incision, and then you put in viscoelastic, and then it oozes out through. And then you again have to suture the wound, which defeats the whole purpose of doing this because you have a lot of irregularity, unpredictability. You can go there again with IA and you can see it again leaks the eschimosis. Let us look at the peer-reviewed journals. All journals, without fail, all the articles and all the peer-reviewed journals say that cataract surgery with toric IOL implantation have a much better results. Visual outcome, rotation stability is very good. Yeah. So this is one more study by Paul which showed that toric IOL was favored for higher degrees of astigmatism. Toric IOL implantation was more effective and predictable between 1 to 3 diopters of pre-existing astigmatism when compared to incisions. So even Robert Pineda says that toric IOLs reduce lifetime economic cost by reducing the need for glasses or contact lenses. My personal experience, I have done more than 600 toric IOLs the past 8 years. Rotation rate is less than 1 degree. Average residual astigmatism less than 0.5 diopters in 94% of cases. And if you look at the market, the thing speaks for itself. Overall growth of toric IOLs in the Indian market is 25 to 30% year on year from 2011. So more people adopting to this technology. So I would like to conclude that there is no debate. Toric IOL is a clear choice for correcting astigmatism during cataract surgery. Thank you very much.
Dr. Ramesh?
Thank you, Dr. Madhivan and the judges. Yes, toric IOLs are good, but they also have their drawbacks. One of the most important one is the cost and the precision. Everybody would like to be Dr. Sri Ganesh. I would like to be Dr. Sri Ganesh, but I can't get that 1 degree, 2 degree precision. Yes, and we have options. And these options are, as he has already mentioned, the incision treatment, that is LRI, and the femto-assisted LRI. Now, the manual LRI, I would like to stress that's because of the cost effectiveness, and especially in a place like India, you need to have options where the more the cost effective, the better. Excimer, the other option is the excimer, and one of the easiest way is to place the surgical wound along the steep axis and extension of the incision to get the astigmatic result. Now, when you actually look at the instance of astigmatism in cataract patients, you see 68% less than 1 1 to 2, 25%, and more than 2 diopters, 7% are only more than 2 diopters. LRI gives very good results for up to 2 diopters. Yes, sir, what you said is right. And we are talking about the majority of the patients who fall in the bracket of the less than 2%. And its effectiveness, if you see, enough studies are showing, compare favorably with the results that have achieved with toric IOLs, achieved a mean reduction of up to 0.5, 60%, and the LRIs also gives up to 60%, more or less the same. And and why better? The only thing I would say is inexpensive, easy to perform, very forgiving surgery. It's in the periphery, unlike the CRIs. It doesn't involve the visual axis, no glare, no hazards, what we were talking about previously. Very minimal instrumentations. The need of a blade also now, we have guarded blades now, 600 microns diamond blades. You don't need to perforate much, as was shown. Can be done at the time of cataract surgery. Impact of cataract is just like a cataract healing, minimal. Most importantly, it can be repeated. Most importantly, the complications, yes, whatever you saw, overcorrection, undercorrection, if there is undercorrection, you can always go back and redo the surgery. Mammograms are now available, very well placed, and you have an online calculator, just like the toric IOL. All you have to have is internet connection. Go to the lricalculator.com, AMO is giving it. Just feed all the mammograms. You have 2 mammograms, very well, low field mammograms, and which means age and pachymetry. This one, what he said was right. There is age and pachymetry difference. Now we have excellent mammograms which give age and pachymetry asjusted NAPA mammograms, and planning. All you need is just a keratometry, identify the axis, compare, rule out lenticular astigmatism, and have a pachymetry. Now everybody will have a pachymetry machine. You can ensure and rule out ectatic disorders. Every procedure will have its contraindications. These ectatic disorders are contraindicated. All you need here is mark the central steep axis and the planned one, where the one which shows the online calculator which shows the extent of incision that has to be given, and just take the guarded 600 microns knife or a 500 microns knife, half or 1 millimeter into the cornea, just make a small incision into this one. If you have a guarded diamond knife or a guarded regular sharp knife which guards you, you don't have a perforation unless you really enter into the cornea. And that's the guarded knife which gives you the 600 microns. The other aspect is the excimer laser. Yes, it's excellent, repeatable, and in cases where a perforation, traumatic cataract, and in this case where there is an ACOL I already put, I think the options that is available is only excimer laser, especially in older patients where the epithelium is easy and not well adhered. So you can also treat the residual pericular in such cases, less stressful. The latest, the femtosecond, wherever you go now, they are talking about, along with cataract surgery, LRIs that are assisted. The new mammograms coming, 30% undercorrection for the regular mammograms, and are giving excellent results. I think you have better options available now for toric IOLs.
My dear colleague believes in eating like this. He wants to use multiple devices for diagnostics, pachymetry, thickness. Then he wants to buy an examiner laser and a femtosecond laser.
Options.
And he's talking about costs.
These are options available, sir. These are options available.
Yes, options. But then
you have
LRIs don't work. Because the LRIs don't work, you have to invest in a femtosecond.
These LRIs were not working. The femtosecond guys will never invest so much.
You need to
introduce it
invest
into
in
a
a
newer
laser, like he said, because to treat
I think I'll start speaking at the same time like Arnab Goswami does.
Yeah.
Thank you very much. We'll go with the technology. I think toric IOLs is the way to go. Thanks for an excellent debate.
Thank you.
Thank you.
We come to the last pair of speakers, Dr. Krishnamurthy, Dr. Manoj Khatri. When you have a rhegmatogenous retinal detachment as a primary procedure, will you like to do a scleral buckling? Really a wonderful procedure. Dr. Krishnamurthy is going to talk on that. And Manoj Khatri is going to say, I am going to jump into the vitreous and then proceed. Dr. Krishna is the son of Dr. K.R. Murthy. I think AIOC is one conference that I think miss your dad. I also listen.
Thank you, sir. We're into the last debate, retinal break. To attach the retina and to produce a strong chorioretinal adhesion around the break. This is a successful retinal reattachment surgery. Now these two routes can be judged. They can be judged with different yardsticks. And if science is used as a yardstick, then I feel that the scleral buckle surgery distinctly has an advantage because it's a very scientific surgery. Here, it involves diligently identifying all retinal breaks, supporting all the breaks on a buckle, producing chorioretinal adhesion around these breaks, and to attach the retina. If economics is used as a yardstick, then the comparison is a no-brainer. The scleral buckle surgery can be done with a handful of instruments, whereas a vitrectomy surgery would require an expensive vitrectomy machine along with all its paraphernalia. However, the scleral buckle surgery is especially tailor-made for certain difficult situations, such as a high myope with a posterior staphyloma and a lattice with a hole. Of course, most of these cases do not have a PVD, and embarking on a vitrectomy surgery as a primary procedure in these is fraught with danger. Similarly, so with a young patient with a peripheral retinal dialysis, they often don't have PVD, and in order to do a good job, it's often indicated that you will have to sacrifice a lens. In phakic retinal detachments, it's better to buckle than to leave behind a peripheral skirt of vitreous. Whenever I'm faced with a dilemma, and when I have two choices in front of me and I have to make a choice, I usually think of my teacher. He always used to say, do the least number of things that you need to do to achieve the results that you want to achieve. Here I think the logic holds very well. Scleral buckle surgery is an extraocular surgery with far fewer steps than vitreous surgery. Here the internal milieu is totally unaltered. That means you leave the eye behind almost in as much of a physiological state as possible. And we all understand that endotamponats such as gas and silicon oil increase the incidence of cataract. Scleral buckle surgery is a face-saving surgery, yes, for the surgeon. Because take this scenario. Patient comes to you with a retinal detachment, the retinal break, and then you advise him a scleral buckle surgery. You say that you're going to support this break from outside the eye with the buckle. In the rare instance that there is a recurrence, you can still be convincing enough when you say, look, your condition was not completely set right with the support from outside. I need to support it from inside as well. Whereas if you've done a vitreous surgery in the first stage, you'll have to tell him that I'll have to do the procedure all over again. And he's most likely to react and say, but doc, I thought you did all that in the first surgery. Did you not do it properly? I'd like to end my part by, bringing for you a small saying from, it's from Kannada, but when roughly translated into English, that's what it would sound. And Dr. Ram would have seen it behind many of these lorries. When your wife enters your life, that lovely dancer, don't forget the mother who gave you a first morsel.
Change. Good evening, everyone. First of all, let me congratulate Dr. Krishna for a wonderful talk. My topic to debate is how we have a patient who has a retinal detachment which is rheumatogenious in nature. What will be your primary procedure of choice? My talk has been divided into a couple of sections. First, what is evidence as of now today where we stand? What has evolved in basic understanding of the disease per se? And what is newer technology which has given us the way to look forward, and what are we doing as of now? I have no financial disclosures to make. The debate always starts with whenever there is a disagreement on the management strategies, which we have already looked upon into several ophthalmic diseases already, which we've spoken about. However, when we compare management of rheumatogenious retinal detachment, it's a very difficult thing to compare between a buccal as well as vitrectomy, because for both the surgeries, the art and science as well as the indications are entirely different. You cannot compare a scleral buccal as well as a standalone transvaginal vitrectomy. However, the incidence of only a simple rheumatogenious retinal detachment, which is a sure shot indication of a scleral buccal, which I also will perform as my first surgery if I have a patient like this, is only 30% nowadays, and it is decreasing with every passing year. The complexities of the nature of the disease are the main reason why this is decreasing over the period of years. Now, the understanding of retinal detachment has gone in view of rheumatism's detachment is such that the tractional component, that means something has to pull the retina or to cause a break. It can be a pre-existing thing like in form of a lattice, which is a degeneration or operculated tear, and then only the rhegma develops. That means the traction is there. So even if you are doing buccal, you are not relieving the traction to the extent which has been required. The other forms of detachment we are not going to discuss. Recent publication by Ferencun et al. In Ophthalmic Research 2014 Jan issue has given us a deep insight into the term which is termed as vitreoschisis, which was initially used only for proliferative diabetic diseases and yeast disease, inflammatory diseases like that. But nowadays what he has depicted is, if you think this is a vitreous gel and you see a patient who has a PVD, that is a posterior vitreous detachment, which has developed a retinal detachment because of PVD. This is the anterior edge of the PVD as shown with the dotted line. But the whole cortical gel is here, which is attached to the retina below. And unless and until we remove this cortical gel and the membrane which is existing between these two layers, we are not going to relieve the traction and not doing any good to the patient. So we need to look into the management strategies which have been already described. I don't have to tell the merits of vitrectomy systems which are available, especially with 23, 25 and now even 27 gauge. They are endless. Also, surgeon's perspective, the whole perspective has been changed. However, the literature tells us there was a major review done by SPR study, that was a scleral buckling versus primary vitrectomy in retinal detachments. In spite of being a multi-central trial, they have not been able to conclude which surgery is superior for a patient who has a simple rhegmatogenous retinal detachment because of variable parameters what the surgeons have used. However, on the other side, in the beginning of small gauge vitrectomy systems in 2005, there was a RCT done and which clearly says that the primary vitrectomy offers potential advantages over conventional scleral buckling surgeries. However, it has to be done meticulously. That means vitrectomy also has to be done very meticulously and judiciously. For resident's perspective, it is little easier to learn and master as compared to a scleral buckle. And for patient's perspective, it is much more tolerable, and also the post-operative outcomes are little earlier. This has been a patient operated by me on day 1. This is an adult patient and this is a pediatric patient whom we can see. There is an excellent comparison. And just a couple of videos to share in which the main indication was scleral buckle. This is a phakic patient, presents to me with a traumatic large hole here. I would have done the scleral buckle and get away with it, but I thought let me proceed with vitrectomy. The macula was just shallow off. You can see here how sturdy is the retina, there is no jump. You can easily induce posterior vitreous detachment in these patients without large trauma to the retina. The macula was just shallow off, clean up the base very nicely, settle the retina without any scleral buckle or a belt buckle and get away with the case. This was a simple case. If you go to a little complex case where you have a pseudophakic rhegmatogenous retinal detachment presents after cataract surgery, you have one break here which can easily buckleable. But to my surprise, the initial break was, there was one more break which was present. I took this patient was again for vitrectomy. Superior break which was quite buckleable has been dealt very well. But we will come to the inferior half of the retina. If we have to take this patient for buckle, we need to put buckle in 2 or 3 quarters at least so that it increases your surgical time and so on. I took this patient for vitrectomy with excellent result. The patient was 6 third day.
Your time's up, doctor.
Just last lecture. So RRD with PVR, this is another indication. This patient had an inferior break, can be buckleable very easily, but again vitrectomy gives a lot of advantages and it's definitely advantages over scleral buckle. If you look OCTs which are post-op, buckle takes lots of time if the drainage has not been done. As you can see here, serial OCT is done for a buckle patient as compared to a vitrectomy group of patients. However, sutureless vitrectomy, though it's a way to go, but we need to understand the primary pathology is of paramount importance. The decision making between buckle and vitrectomy has to be made keeping in mind the final outcome, what you are looking for the patient, and ultimately which is going to benefit the patient. Thank you very much for the patient hearing.
Krishna, you like to tell something?
I would just like to reiterate what I said, that I have nothing against the vitrectomy. I stand here to defend the scleral buckle, but nothing against the vitrectomy. what Dr. Khatri has brought out are very valid points, but as I said again, these are basically two different routes reaching the same destination. I'm not saying that one of them won't reach there, you will reach there, but my agenda here is to defend the buckle, and I hope I've done that well. Thank you.
Yeah, Dr. Krishnamurthy and Dr. Manoj Khatri both win. Dr. Krishnamurthy for his speaking skills and Dr. Manoj Khatri for the technical points he's brought out.
Both win. Thank you very much.